So good morning. It's my pleasure to talk to you today about diagnostic challenges in anal neoplasia. These are my disclosures. None of these have any conflicts with the contents of this talk. So a brief outline of the agenda and objectives. I'm going to very quickly talk about normal anatomy and histology of this region. We'll go on to diagnosis of squamous cell carcinoma and its precursors, then talk somewhat about adenocarcinoma and Paget's disease, and mixed in will be some consideration of some more uncommon entities. So the anal region, comprising the anal canal and the perianal area, can be defined in several different ways. For a surgeon, the proximal limit is the lower limit of the levator ani and also the area of the internal anal sphincter. Whereas the anatomic definition, the proximal extent is a little bit more distal at the dentate line. The sort of upper limit of the anal canal and the lower limit of the columns of the sort of anal columns. And so the upper region of this area is lined by colonic mucosa, recognizable as glandular mucosa at the top, very simple, the distal rectum. This can undergo some squamous metaplasia. In the middle is a very narrow region of transitional mucosa, which is stratified, somewhat of a hybrid phenotype. And then the anal canal proper is lined by a non-keratinizing squamous epithelium. So this is distinct from the perianal skin, which contains hair and other adnexal structures, and is also a sort of true epidermis, lined by epidermis. So I want to talk first about anal squamous cell carcinoma. So this has some relatively well understood epidemiologic risk factors. This is true in most regions of the world. This includes HIV positivity, men who have sex with men, and in females in particular, the presence of gynecological precancers as well as HIV status, and also immunosuppression for any reason is also a risk factor. And this figure here, which is from a recent review, just illustrates the relative risks for these various conditions. So you see in HIV positive individuals that is significantly raised over HIV negative patients, and also but generally it can be as high as 100 cases per 100,000 person years. Most of these studies that this particular study is analyzing are really from the Western world. There's less epidemiologic data in the Asia Pacific region. This is true for both HPV-related cancers in general and for specific sites such as the anus. The studies that have been published indicate that the incidence rates are generally in the same ballpark as in the Western world. Anal, but relatively few studies, so there's a wide range of reported incidences. So for anal canal, carcinoma, for example, it's anywhere between 0.2 and 13.7 per 100,000 person years. But all the available data indicates that the same risk factors apply, and also similar high-risk HPV subtypes are involved. But I think it's reasonable to conclude that there is a relatively high burden of HPV-related diseases, not just anal, but cervical and head and neck and others. When we diagnose anal and perianal precursor lesions, this classification has evolved over the years, but we generally use the College of American Pathologists, or LAST classifications, which is a dichotomous division into low-grade squamous intraepithelial lesions, or LSILs. This includes condylomas, and also and then HSILs, high-grade squamous intraepithelial lesion. And this encompasses other terms that have been used in the past, such as carcinoma in situ, severe dysplasia, Bowen's disease. And I think the key biologic point is that this dichotomous classification is reflected in the involvement of low risk or high risk HPV subtypes, such as 16 or 18 for HSIL. And you may use a different classification depending on your local preference, but generally I would say that it certainly needs to be consistent and understood by your clinical colleagues. Our general practice is to use the last classification, line diagnosis of HSIL, LSIL, or negative, with an AIN designation if appropriate, and I'll talk about that in a moment. So this is an example of reactive squamous epithelium. It's somewhat inflamed, but I think it has a number of features which are reassuring that there's no dysplasia. For one thing, it's a maturing epithelium. There is some degree of inflammation, some spongiosis and edema, a little bit of parakeratosis at the surface, but there is no significant nuclear hyperchromasia. The nuclei are relatively even, they're not overlapping. And so this is relatively orderly. On a pap smear, which I won't be talking much about cytologic findings, but this is a good example of a reactive squamous epithelial population. There's a low NC ratio, uniform nuclei, and admixed neutrophils. And the distinction between reactive squamous epithelium and low-grade squamous intraepithelial lesions can be tricky at times. In this particular example, we're contrasting some squamous epithelium negative for dysplasia with an LSIL lesion. This particular sample has some coilocytosis in the superficial layers. You see these nuclear enlargement and some perinuclear halos. And in the lower third of the epithelium, we do see some slight but definite hyperchromasia and nuclear crowding. There's also a suprabasal mitosis right here. This is very helpful in distinguishing a dysplastic from a reactive population. But it's limited to the lower third of the epithelial thickness, so AIN1. Now here's an example of a condyloma, which we would also consider in the LSIL category. This particular, is recognizable as a raised lesion that was removed by the clinician. So it does look a little bit thicker. And in the superficial aspect of the epithelium, you do see, again, coilocytosis. Again, this would be the cytologic finding in a pap smear of these coilocytes with their nuclear halos. This particular lesion also does not have any basal dysplasia, so no AIN, but still in that LSIL category in the last classification. This is an example of an HSIL. This is AIN3 because the dysplastic epithelium occupies greater than 2/3 of the epithelial thickness, and we recognize the nuclear hyperchromasia, lack of maturation, overlapping, the presence of many mitoses high up in the epithelial thickness. So this just looks very dark at low power, and when we go to high power, we can see those nuclear features. And this is also illustrated in this pap smear right here, quite a distinct difference between a normal squamous epithelial cell and these dysplastic squamous cells with their degree of nuclear pleomorphism, coarsened chromatin, high mitotic index, irregular nuclei. So there are a number of diagnostic issues that are very persistent in this area. I think from a more sort of overall practice perspective, one question as far as specimens that we do receive is, who to screen. So I think on the clinical side, identifying high-risk groups and determining sort of how to screen them and whether and how to screen them. And then I think when we get a specimen, whether it's cytologic or pathologic, there are known issues with reproducibility of the diagnosis, and this is true in both screening and surveillance modes. Part of this is the nomenclature, varying criteria. Also, some observers may be inexperienced with this particular area, and there is undeniably some inter-observer variability, particularly in difficult cases. And then I think a sort of further question more generally is, how are abnormal results followed up, and kind of how is that information communicated, and then what is done with them. And I think one sort of sobering point that I think was raised in a recent review of the literature was that there is a lot of variability in reporting terminology. So this particular study looked at what proportion of published of English language publications use the L-SIL, H-SIL nomenclature, kind of the current, what I would consider the current standard. And they found actually that although it has varied over the years, and there was a little bit of an increase in usage after the introduction of the last recommendations in 2012, it really is still kind of hovering in the kind of 40 to 50% range, and the remainder used the AIN nomenclature or sometimes combined nomenclature. So I think this does illustrate that there's a lot of variability in the published literature, and it does have implications for reproducibility and applicability of results as they're being applied. I think also, and again, another issue is, kind of what sort of screening method is being used to identify patients who have anal squamous neoplasia. And there are a variety of possibilities. That probably the most traditional one is cytology and anal pap smear. This is a particular, these are the results of a meta-analysis that was done of 39 studies in US, Europe, and including some Thai studies, which found that if one uses a gold standard of detection of H-SIL lesions, AIN2 or worse, if one takes the cytology ascus or worse, atypical squamous cells or worse, that's relatively sensitive for the detection of these on subsequent biopsy, but the specificity is only fair. If one limits this to an H-SIL diagnosis, the specificity is quite high for H-SIL on biopsy, but there is a trade-off in very low sensitivity. So, I think, and other factors involve sort of a relatively poor correlation with AIN grade, or L-SIL versus H-SIL grade, a relatively high unsatisfactory rate in the cytology specimen, and a low positive predictive value, as well as the problems with reproducibility. If one looks at viral DNA testing alone, that is quite sensitive, but relatively low specificity. And if one limits the viral testing to only specific high-risk subtypes, there's a trade-off of a high degree of specificity but low sensitivity. Unfortunately, if one combines cytology and HPV co-testing, which seems like a sensible approach, there doesn't seem, at least based on the data so far, much of a improvement in specificity while retaining a high degree of sensitivity. So I think that does question the sort of added value of co-testing over HPV testing, but this is definitely an evolving field. And I think there's some factors like the use of P16 immunohistochemistry in biopsies which haven't really been addressed. But these are the current anal cancer screening guidelines by the International Anal Neoplasia Society. The populations to screen, we've already mentioned these. These include persons with HIV, women with vulvar dysplasia or vulvar cancer, men who have sex with men without HIV, and solid organ transplant recipients, and as well as a category B, with lower incidence. So generally, the screening method is digital anal rectal exam, anal cytology, with or without anal HPV testing, and then standard of care is for the abnormal result to be followed up by a high-resolution anoscopy. And this is a very sort of helpful technique because it does allow a direct examination of the anal canal, and we see here a view of one of these anoscopies where Lugol's iodine has been applied, and so the Lugol negative regions, which do not stain with this dye, are more likely to contain squamous intraepithelial lesions. So this would be an area to biopsy. And also potentially can be ablated with electrocautery or laser, or could be treated with topical agents. So this has shown actually some efficacy in clinical trials. So these are the results of the Anchor trial, which is a phase 3 trial performed at 25 US sites on HIV positive patients who had a biopsy-proven HSIL in their anus, and they were randomized to either receive HSIL treatment, similar to what I mentioned, or to active monitoring without treatment. And these patients all had a high-resolution anoscopy every 6 months. The result was a reduction in the incidence of anal cancer over the follow-up period of about 4 years. Although again, the sort of absolute incidence of cancer is relatively low, even in this high-risk population, about sort of 1 to 2%, there nevertheless was a significant decrease in incidence. So that's very encouraging, and does indicate that this sort of approach, can produce positive results in this population when applied in a dedicated fashion. But this is, this does, encouraging as this is, it does, raise some issues, and a lot of this revolves around access to resources. So high-resolution anoscopy is a definitive treatment in a screened population, but it may not be available because of cost, facilities, or trained personnel, availability of trained personnel. And I think one has to always question whether a screening program can be effective and is cost effective, worth the effort without a sufficient follow-up or surveillance resources. And of course, there are treatment options other than high-resolution anoscopy. These include HPV vaccination, HIV antiviral therapy in HIV-positive patients. So these certainly, can have an impact on the natural history as well. So getting back to the pathology, again, in distinguishing reactive lesions from L-CILs, AIN1, or H-CIL, AIN2 and 3, I think the most helpful features are really to look at the nuclear features. So H-CILs will have a high nuclear cytoplasmic ratio, hyperchromasia, pleomorphism, loss of maturation, whereas reactive epithelium will not have these things. There's also, I think, I want to talk in particular about the use of ancillary stains such as P16, which can be helpful in difficult particular biopsies. We regard P16 immunohistochemistry as really the mainstay because it is very helpful in distinguishing hyperplastic, sort of non-dysplastic or atypical squamous epithelium from true dysplasia. So this example here of an HSIL, we see this block-like P16 immunostaining in the squamous epithelium. So that supports a diagnosis of HSIL. Other stains such as Ki67 proliferation marker, these can certainly be increased in dysplasia, like we see in this example here, where there's many positively staining nuclei, but this is certainly more than normal squamous epithelium, but there is a considerable overlap with inflammatory lesions. So I would say this is usually not needed, and we do not use it routinely, although it can be helpful at times. HPV viral in situ hybridization, again, usually not needed, but it can be available in ambiguous situations if one's looking for, evidence of high-risk HPV or low-risk HPV infection. And finally, genotyping by direct PCR of biopsies. I would generally not recommend this, although it certainly has a place in cytologic specimens. The experience doing this on biopsy tissue is very sort of prone to difficulties, mainly because of contamination, sensitivity, and also it's relatively expensive compared to a sort of direct analysis of a cytologic specimen. So we really do not do this. And I think it's also important to remember that all of these ancillary tests need to be interpreted only in conjunction with the morphology. So here's an example of what is and is not block-like staining. So on the left, we see two examples where we have confluent strong staining in the nuclei and cytoplasm. And this involves the basal layer. It's really kind of unbroken, although the like in the lower panel, these can be very small foci, but nevertheless, when it does show these characteristics, we can call that block-like. By contrast, the ones on the right, these are not block-like because they're more patchy, sort of isolated cells, and also not involving the basal layer. So that would be sort of negative for block-like staining. Here are some other examples of stain results that are not block-like. So this is on the left is an example of immature squamous metaplasia, which is reactive, so not dysplastic. It does look very crowded, but it doesn't really have cytologic features sufficient for dysplasia. And this again is negative. Same thing with the anal transition zone mucosa we see right here. So negative for block-like staining. Here's an example of a condyloma. We see the coilocytosis at the surface here, and this shows a very patchy, weak P16. In this particular example, in situ hybridization for low-risk HPV was done, and we see some positive signal here corresponding to the coilocytes. Here's a somewhat, I would regard somewhat of a challenging biopsy because it does show some areas of nuclear crowding, particularly in the basal layers. I'll show this a little higher power. We see again these sort of dark, perhaps overlapping nuclei, but there's also a superficial area that seems to be a bit more edematous, and there is some evidence of maturation. So really, this could be anything from a reactive epithelium to a to an AIN1, or maybe even an HSIL lesion that's a little bit obscured by some injury. So a P16 is very helpful here. We see that it's showing a non-block-like pattern. I think on careful scrutiny, I think again this was somewhat of a difficult case, but I think we decided that there was some evidence of basal dysplasia in the lower third. So again, we decided that this was an LCIL or an AIN1, but the P16 was very helpful. Here's another biopsy where at very low power, we see we're at the anorectal junction, and there are a few areas where even at low power, it looks like the nuclei are sort of very crowded. It's a little more blue, looking those a little more close up. You see again, this perhaps is a full thickness lesion in AIN3. This is again could be an AIN1 or an AIN2. It's a little hard to tell how far up the atypical squamous epithelium goes, but when we look at the P16, you see there's this very big field of block-like staining. So this is really it's a whole area of HSIL that is occupied by this. I think I didn't mention this before, but the reason P16 is helpful here because it is a good surrogate for the cell cycle changes that go on in HPV, high-risk HPV infection. So this is not a direct detection of the virus, but on its effects upon the cell cycle machinery. And here's finally one last example of a reactive squamous epithelium that looks very jumbled, somewhat injured, but there are definitely some enlarged cells here, but again, not a block-like staining pattern, so a reactive squamous epithelium. So just to summarize the indications and use of P16 immunohistochemistry, it's very helpful in distinguishing HSIL from either reactive or LSIL. Block-like staining supports the presence of HSIL. If there's a difficult case where there's disagreement over the histologic diagnosis among our group, we'll often use P16 as a sort of helpful thing to sway us one way or another. But I think if the histologic diagnosis of a reactive LSIL or HSIL is straightforward, I don't think there's much call for a P16 because again, the histologic diagnosis is straightforward and the stain result could be potentially confusing. However, it has been found that P16 is sort of helpful in improving agreement, decreasing inter-observer variability when it comes to assigning an AIN grade compared to the use of H&E alone. But even there, with P16 or even just in general, if one looks at cytology and biopsy samples, the best we ever get is really a sort of moderate agreement, a kappa value of 0.5 to 0.6. So that's just illustrates the kind of difficulty sometimes in evaluating these biopsies, but and why ancillary tests such as this can be very helpful. Another issue in the pathology of these is assessing for invasion in poorly oriented biopsies. So this example, I think we can be fairly comfortable that this is an HSIL, probably an AIN3 in places, but it's not very well oriented. We see some tangential cutting of some of these lamina propria reedy pegs. There are these, it appears somewhat thickened, and there's, maybe a suggestion of some downward extension, but these have fairly rounded contours. So I think it's definitely possible that this just represents a sort of poorly oriented cut of the surface. So I would say that this is sort of a HSIL, but no definite invasion. And here's another biopsy, again, not very well oriented. We have a lot of tangential cuts of the surface. It's also very inflamed, and we do have these isolated, what appear to be perhaps isolated nests of squamous epithelium in the middle of this, but I think it's difficult to exclude reactive pseudoepitheliomatous hyperplasia. So I think again, we're not able to come to a diagnosis of definite invasive carcinoma, and recommended that the patient undergo a rebiopsy if that was indicated. Another situation that can come up that is not invasive carcinoma is HSIL that extends down into either anal glands or into colonic crypts if one is near the dentate line. So this example, we see a AIN3 HSIL lesion, which appears to be continuous with a colonic crypt right here, and it's highlighted nicely by this P16 stain. But again, these are rounded nests, and they are not infiltrating deeper layers. And then finally, another sort of difficult situation, it would be when one has a biopsy with small detached foci of HSIL. The example at the top is one where the HSIL appears to be within a lymphoid aggregate, confusingly, and this other one at the bottom is where you have these detached foci of HSIL just kind of untethered from the surface. So, I think we're comfortable with the diagnosis of HSIL, but it's not possible really to make any other statement about whether there's invasion. But, and I think also in addition to the screening and surveillance setting, one has to consider the possibility that, one can have an HSIL or an early cancer in just as an incidental finding. This particular one is from a hemorrhoidectomy, where we see this area of AIN3 HSIL and what I would interpret as a superficially invasive squamous cell carcinoma, although this is somewhat challenging also because of these rounded nests. But, certainly unequivocal invasion, we look for the presence of irregular nests of cells, a true downward extension in a well-oriented specimen, and also evidence of keratinization with keratin pearls here. So I think this particular biopsy, I think there's no question that this is showing well-differentiated superficially invasive squamous cell carcinoma. And squamous cell carcinoma can fall anywhere along a differentiation spectrum, from very well differentiated lesions with a lot of keratinization to poorly differentiated tumors, formerly called non-keratinizing squamous cell carcinoma, where it can even be hard to even recognize that they are squamous. And also at the well differentiated end, one can have so-called verrucous squamous cell carcinomas that have Pushing type invasion and mild to minimal atypia. But these verrucous carcinomas, interestingly, don't appear to be HPV associated, but they can show, they can also be associated with conventional squamous cell carcinomas, but they should be distinguished from a so-called giant condyloma or Buschke-Lowenstein tumor, which is an HPV lesion, but not a cancer, low risk HPV associated, but again will mostly show exophytic growth and can become quite large and cause a lot of morbidity, but are strictly speaking not malignant. So those can be difficult to distinguish from each other. And most recently, from a paper earlier this year in Modern Pathology, there's also a report of another type of HPV independent squamous lesion called an ANGEL, anal growth intraepithelial lesion. These are more sort of verruciform acanthotic lesions with a lot of hyperkeratosis, The angel-associated squamous cell carcinoma is well to moderately differentiated, has a pushing border. I actually wonder if this is really just kind of another version of a verrucous carcinoma, but I guess it does have some differences, but the distinction may be somewhat arbitrary. Squamous cell carcinomas can also have a basaloid morphology with a very compact cells, scant cytoplasm, often with some peripheral palisading reminiscent of basal cell carcinoma of the skin. These can be also admixed with more conventional squamous cell carcinomas. They often have this hyaline material and microcysts. But I think although this used to be considered a distinct entity, it's really just a morphologic variant of squamous cell carcinoma and is usually HPV associated. But in very poorly differentiated examples or in small biopsy material, this can be easy to wonder if this represents a neuroendocrine carcinoma or some other poorly differentiated neoplasm. So here's an example of an anal mass that was removed. This is also a kind of a poorly differentiated tumor. Very solid cells, so the fairly wide differential for this. But one clue actually is if one looks at the squamous epithelium overlying it, there's actually some junctional melanocytic activity. So we see some lentiginous spread, also some nests. These are highlighted by the MART1 immunostain. So this is in fact an anal melanoma. So anal melanomas can arise primarily at this site. Like melanomas elsewhere, they can have varying morphologies. They can be epithelioid or spindled. The example on the right has some pigment production as well. But I think when one encounters a poorly differentiated tumor such as this, there often are morphologic clues. There may be a sort of better differentiated area of the tumor. There may be a history of a rectal tumor in the case of a poorly differentiated adenocarcinoma or a precursor lesion. But I think in thinking about a poorly differentiated squamous cell carcinoma, adenocarcinoma, or neuroendocrine carcinoma, melanoma, lymphoma, morphology and also appropriately chosen immunostains will usually help sort this out. And also, I think the location of these lesions can be, a very helpful guide. Again, if one divides the sort of anal and perianal region into zones, the lower rectum and anal canal, we will see adenocarcinomas, various types of squamous cell carcinomas. In the perianal region, we'll tend to see the giant condyloma, verrucous carcinoma, Paget's disease, skin adnexal tumors, neuroendocrine carcinomas more proximally, and then melanomas in the anal canal. And it's important also to remember that the perianal region encompasses tissue that's within 5 centimeters of the anal verge. So anything more distal than that is staged and classified as a skin cancer. Moving on to adenocarcinomas, this is an example of a mucinous adenocarcinoma that arose in a patient with Crohn's disease who had a fistula in the perianal region. So these are, again, often but not always mucinous. Typically will show an intestinal phenotype, keratin 20 and CDX2 positive. They often, they often may be associated with a precursor lesion within the fistula. So these are some examples of glandular dysplasia occurring within the fistula. This is, often not readily seen on biopsy material, but in these resections, we were able to find some dysplastic epithelium. So the history of Crohn's obviously is very important to make this connection. And this is an example of an anal gland adenocarcinoma. So there's a population of glands that reside in the anal canal that can rarely give rise to malignancy. So these are usually non-mucinous gland-forming cancers. The glands often are very sort of small caliber, or the cells can be more nested. There is no surface precursor, but the tumor cells can actually spread into the squamous epithelium in a pagetoid fashion. And these usually show an opposite phenotype. They're non-intestinal, so different from Crohn's associated cancer different from a rectal adenocarcinoma. There's also a recent report of a HPV-associated adenocarcinoma, so-called SMILE or stratified mucin-producing carcinoma. This is an illustration from that paper, again showing that it is associated with a glandular dysplasia, and also is P16 positive both in the precursor and in the cancer. So this is really analogous in some ways to endocervical adenocarcinoma or cervical adenocarcinoma in situ, which is also an HPV-associated lesion. So here's just a brief table. I won't go into this in detail, but this just highlighting some of the morphologic and immunohistochemical differences among these various types of adenocarcinomas that arise in this region. I want to say a little bit about Paget's disease of the anus. This is so pagetoid spread or Paget's disease is defined as infiltration of the perianal skin, generally that area by malignant mucin-producing cells, often singly or in small groups. So here's a perianal biopsy showing some of these Paget cells here. It can also occasionally involve the anal canal as well. This typically in the perianal region will affect older patients who present with sort of an inflammatory dermatosis and pruritus. And important to remember that this can be primary or secondary. Again, we've seen an example of an anal gland carcinoma producing this. And here's an example of primary anal Paget's disease. Again, some of these cells look somewhat signet ring cell like in their morphology. We can highlight them with mucin stains such as Alcyon blue or immunostains such as CEA, although they're not obviously not specific for a particular origin, but just highlight their glandular nature. Here's an example of a secondary Paget's disease. Here's pagetoid involvement of the anal canal mucosa by a rectal adenocarcinoma. So we see some mucinous adenocarcinoma below the squamous epithelium, and up in the squamous epithelial surface, we see some, hard to see at this low magnification, but there are some infiltrating cells within the squamous epithelium, and we can highlight them with a CDX2 immunostain, confirming that they are, rectal in origin. So, when one encounters these sorts of Paget cells on a biopsy, if the clinical background is not clear, often a well-chosen panel of immunostains will be helpful to distinguish primary and secondary Paget's disease, also anal gland carcinoma, melanoma, which may of course have melanocytes within the squamous epithelium spreading in more of a pagetoid fashion, and also pagetoid spread of HSIL can occur. So, one needs to, consider all those possibilities and kind of in context of other disorders that the patient has. So I want to finish up with one of the just a few kind of inflammatory lesions that sometimes will masquerade as a neoplastic process, and mostly we're talking about rectal tonsils, prolapse polyps, sometimes common diseases such as hemorrhoids or anal fissures and fistulas, which we've already made reference to. Here's an example of a rectal tonsil or a sort of reactive lymphoid hyperplasia. This is very well ordered, architecturally intact lymphoid tissue. So this may be excised as a nodule, but I think it's fairly easy to recognize this as being, benign lymphoid tissue. It can raise a diagnosis with lymphoma, but you would typically see a more atypical lymphoid infiltrate or a certainly an effacement of the lymphoid architecture. If it's associated with some sort of inflammation, one would consider, potentially a lymphoid follicular proctitis in the setting of ulcerative colitis, or even syphilis, which would be more of a diffuse lymphohistiocytic inflammation and more of an ulcerating process. But that's usually apparent that one is looking at a discrete lesion here. All right, that is the end of my talk. I want to thank you very much for your attention, and I will be happy to answer any questions. Thank you very much.